Today, we're talking about a chronic disease that millions and millions of people unfortunately have and may not even know it. This way for peripheral neuropathy. Hey everybody, as I said, we're doing peripheral neuropathy, but I was supposed to do this actually in September, but it kind of got away from me, so apologies. So we are starting off October, the wonderful month of October, with this chronic disease spotlight. So let's get into what exactly peripheral neuropathy is. So peripheral neuropathy, there are more than 100 types of peripheral neuropathy, each with its own set of symptoms and prognosis. So more than 20 million people in the United States have been estimated to have some form of peripheral neuropathy, but this figure may significantly be higher because not all people with symptoms are actually tested for the disease, and testing currently doesn't look for all forms of neuropathy. So what exactly is peripheral neuropathy? And a side note, for the rest of this video, I'll refer to it periodically as PN. So PN actually refers to many conditions that involve damage to the peripheral nervous system, which is a vast communication network that sends signals between the central nervous system, or the brain and spinal cord, and all the other parts of the body. So peripheral nerves send many types of sensory information to the central nervous system, or the CNS, such as a message that the feet are cold. They also carry signals from the CNS to the rest of the body. Best known are the signals to the muscles that tell them to contract, which is how we move. But there are different types of signals that help control everything from our heart and blood vessels, digestion, urination, sexual function, to our bones and immune system. So the peripheral nerves are like the cables that connect the different parts of a computer or connect the internet. When nerve signaling malfunctions, complex functions grind to a halt. And there's 3 ways nerve signaling in neuropathy is disrupted. First is loss of signals normally sent, kind of like a broken wire. The second is inappropriate signaling, when there shouldn't be any, kind of like static on a telephone line. And the third are errors that distort the messages being sent, kind of like a wavy television picture. Symptoms can range from mild to disabling, but are rarely life-threatening. And these symptoms depend on the type of nerve fibers affected and the type and severity of the damage. So symptoms may develop over days or weeks or years, and in some cases the symptoms improve on their own and may not require any advanced care. Unlike nerve cells in the central nervous system, peripheral nerve cells actually continue to grow throughout life. So let's get into the different types of PN. Some forms of neuropathy involve damage to only one nerve, which is called mononeuropathy. Neuropathy affecting 2 or more nerves in different areas is called multiple mononeuropathy, or mononeuropathy multiplex. But more often than not, many or most of the nerves are affected, and this is called polyneuropathy. This is the one that I actually see the most. Okay, so now that we know what neuropathy is, let's talk about how it's classified, because you'll recall from earlier that there are more than 100 types of peripheral neuropathy, each with its own symptoms and prognosis. And symptoms do vary depending on the type of nerves involved and whether they're motor, sensory, or autonomic that are damaged. So motor nerves control the movement of all muscles under conscious control, such as those used for walking, grasping things, or talking. Sensory nerves transmit information such as the feeling of a light touch, temperature changes, or the pain from a cut. And then autonomic nerves control organs that regulate activities that people do which are not under conscious control, such as breathing, digesting food, and heart and gland functions. Most neuropathies affect all three types of nerve fibers to varying degrees, and others primarily affect one or two types. So we'll use terms such as predominantly motor neuropathy, predominantly sensor neuropathy, sensory motor neuropathy, or autonomic neuropathy to describe different conditions. And about 3/4 of polyneuropathies are length dependent, meaning the farthest nerve endings in the feet are where symptoms develop first or are worse symptom-wise. And in severe cases, such neuropathies can spread upwards towards the central parts of the body. In non-length dependent polyneuropathies, the symptoms can actually start more toward the torso and may be patchy or spotty in the areas that symptoms are experienced. So now let's talk about symptoms. Motor nerve damage is most commonly associated with muscle weakness. Other symptoms include painful cramps, fasciculations, or uncontrolled twitching visible under the skin, and muscle shrinking. Sensory nerve damage, on the other hand, causes various symptoms because sensory nerves have a broad range of function. And there are two types of sensory nerve fibers, large and small. Easy, right? So damage to large sensory fibers harms the ability to feel vibration and touch, especially in the hands and feet. People may feel as if they're wearing gloves or stockings even when they're not. And this damage can actually contribute to loss of reflexes as well, as can motor nerve damage. And we can also see loss of position sense, which often makes people unable to coordinate complex movements like walking or fastening buttons or maintaining their balance when their eyes are closed. That actually sounds like the DUI test, right? When they have you close your eyes and touch your nose and, well, maybe no, maybe that's not it, but anyway. So that was all related to large fiber involvement. So next we're going to discuss small fiber involvement. So small fibers don't have myelin sheaths, which is a protective coating like insulation that normally surrounds a wire, and include fiber extensions called axons that transmit pain and temperature sensations. Small fiber polyneuropathy can interfere with the ability to feel pain or changes in temperature, and it's often difficult to control, which can seriously affect a patient's emotional well-being and overall quality of life. Someone having neuropathic type pain will sometimes notice it's worse at night and disrupts their sleep. A lot of these people just really have a hard time sleeping at night. And this is one of the reasons. And this is caused by the pain receptors firing spontaneously without any known trigger, or by difficulties with the signal processing in the spinal cord that may cause someone to feel severe pain, or what we call allodynia, from a light touch that's normally painless. For example, someone might experience pain from the touch of their bed sheets, even when they're draped lightly over their body. And lastly, we come to autonomic nerve damage, which affects the axons in small fiber neuropathies. So common symptoms of autonomic neuropathy include excessive sweating, heat intolerance, the inability to expand and contract the small blood vessels that regulate pressure or blood pressure, and gastrointestinal symptoms or GI symptoms. And although this is rare, some people develop problems eating or swallowing if the nerves that control the esophagus are affected. So ultimately, there are several types of peripheral neuropathies, as I've said a few times at this point, and the most common of which is linked to diabetes. Another serious cause of polyneuropathy is Guillain-Barré syndrome, which occurs when the body's immune system mistakenly attacks the nerves in the body. There's also focal types of mononeuropathy, meaning they're located to just one part of the body. And this includes carpal tunnel syndrome, which affects the hand and the wrist, and myalgia paresthetica, which causes numbness and tingling in one thigh. And then there's complex regional pain syndrome, which is a class of lingering neuropathies where small fibers are mostly damaged. So what causes PN? So most instances of neuropathy are either acquired, meaning the neuropathy or the inevitability of getting it isn't present from the beginning of life, or genetic. Acquired neuropathies are either symptomatic, meaning the result of another disorder or condition, or idiopathic, meaning it has no known cause. So causes of symptomatic acquired peripheral neuropathy include physical injury or trauma. And this is the most common cause of acquired single nerve injury. So these are injuries from automobile accidents, falls, sports, even medical procedures that can stretch or crush or compress nerves or detach them from the spinal cord completely. It's kind of scary. It's really kind of scary. Less severe traumas also cause serious nerve damage, like a broken or dislocated bone that exerts damaging pressure on neighboring nerves, and slip discs between vertebrae, which can compress nerve fibers where they emerge from the spinal cord. Arthritis or prolonged pressure on a nerve, such as by a cast maybe, or repetitive forceful activities, can cause ligaments or tendons to swell, which narrows slender nerve pathways, such as we see with ulnar nerve neuropathy and carpal tunnel syndrome. So again, in some cases, there are underlying medical causes, such as diabetes, that prevent the nerves from tolerating the stresses of everyday life. And diabetes happens to be the leading cause of polyneuropathy in the United States. About 60 to 70% of people with diabetes have mild to severe forms of damage to sensory, motor, and autonomic nerves that can cause the numbness, tingling, or burning, say in the feet. They can also have one-sided bands of pain and numbness and weakness on the trunk or pelvis. Vascular and blood problems that decrease oxygen supplies to the peripheral nerves can also lead to nerve tissue damage. Smoking and narrowing of the arteries from high blood pressure, or atherosclerosis, which is fatty deposits on the inside of the blood vessel walls, can also lead to neuropathy. What I see a lot of, unfortunately, are systemic or body-wide autoimmune diseases, in which the immune system just mistakenly attacks its own cells and their own tissues, which can directly target nerves or cause problems when surrounding tissues compress or entrap nerves. Sjogren's syndrome, lupus, and rheumatoid arthritis are some systemic autoimmune diseases that can in fact cause neuropathic pain. Autoimmune diseases that attack nerves are often triggered by recent infections, and they can develop really quickly actually, or slowly, while others become chronic and fluctuate in severity. Certain cancers and benign tumors can also cause neuropathy in various ways, and chemotherapy drugs used to treat cancer can also cause polyneuropathy, and estimated 30 to 40% of users will actually experience this. However, only certain chemotherapeutic drugs cause neuropathy, and not all people get them if they're prescribed or on chemo. So yes, I mean, I've seen plenty of chemotherapy recipients complain of the numbness and the burning and the tingling, but not all. Okay. Chemotherapy-induced peripheral neuropathy may continue long after treatment if they do get it. So as treatment ends, they can still go on with these symptoms. And radiation therapy also can cause nerve damage, which sometimes does not present until months or years later as well. Infections can also attack nerve tissue and cause neuropathy too. Viruses also, such as varicella zoster virus, which causes chickenpox and shingles. Another one is West Nile virus, cytomegalovirus, and herpes simplex target sensory fibers, causing attacks of sharp, lightning-like pain. Lyme's disease is another one, carried by tick bites, can also cause a range of neuropathic symptoms, often within a few weeks of being infected. Another is human immunodeficiency virus, or HIV. which causes AIDS and can extensively damage the central and peripheral nervous systems. And an estimated 30% of people who are HIV positive develop peripheral neuropathy. And then rounding out the last few causes are hormonal imbalances, which can disturb normal metabolic processes, leading to swollen tissues that can press on peripheral nerves. There's also kidney and liver disorders, which can lead to abnormally high amounts of toxic substances in the blood that can damage nerve tissue as well. Most individuals on dialysis because of kidney failure do develop varying levels of polyneuropathy. And then finally, any nutritional or vitamin imbalances, also alcoholism and exposure to toxins, can damage nerves and cause neuropathy. Vitamin B12 deficiency is also another huge one, and an excess of vitamin B6 are the best known vitamin-related causes of neuropathy. Several medications have also been shown to occasionally cause neuropathy. So, as you can see, there is a bewildering array of variability of symptoms, which can really make PN or peripheral neuropathy difficult to diagnose. So to do this accurately, your doctor or nurse practitioner will typically start with your medical history. So this is why it's really important to tell everything, all your history, tell the truth, tell any and all indiscretions. Where there's healthcare practitioners for the benefit of you. So it never really pays to hide anything from us, because it really is just ultimately hurting you. So your medical history, this is where we'll ask questions about symptoms and any triggers or relieving factors throughout the day, or your work environment, social habits, exposure to toxins, maybe alcohol use, risk of infectious diseases as well, and a family history of neurological issues, any neurological issues that your parents or your grandparents have had. Physical and neurological exams are next, in which we'll look for any evidence of body-wide diseases that can cause nerve damage, such as diabetes. A neurological exam includes tests that may identify the cause of the neuropathic disorder, as well as the extent and type of nerve damage. Blood tests can also detect diabetes or vitamin deficiencies, liver or kidney dysfunction, or other metabolic disorders, infections, and signs of abnormal immune system activity. So less often, other body fluids are also tested, like cerebrospinal fluid. They're tested for abnormal proteins or the abnormal presence of immune cells associated with some immune-mediated neuropathies. So some additional tests may also be ordered to help determine the nature and extent of the neuropathy once diagnosed. And these include physiological tests of nerve function, which includes nerve conduction velocity testing, or NCV, which measures the signal strength and speed along specific large motor and sensory nerves. And during this test, a probe electrically stimulates a nerve fiber, which responds by generating its own electrical impulse. An electrode placed further along the nerve's pathway measures the speed of signal transmission along the axon. And side note, an axon is a portion of a nerve cell or a neuron that carries nerve impulses away from the cell body. So a neuron typically has one axon that connects it with other neurons or with muscle or gland cells. And some axons may be quite long, reaching, for example, from the spinal cord all the way down to the toes. And this is the part of the nerve that looks kind of like a long tail. Slow transmission rates tend to indicate damage to the myelin sheath, while a reduction in the strength of the impulse at normal speed is a sign of axonal degeneration. Inability to elicit any signals can indicate severe problems with either. Electromyography, or EMG, is next and involves inserting very fine needles into specific muscles to record their electrical activity at rest and during contraction. This tests for irritability and responsiveness, and it detects abnormal muscle electrical activity in motor neuropathy. And it can help differentiate between muscle and nerve disorders. We also do neuropathology testing to look at the appearance of a nerve. And then the main test for this is a nerve biopsy, which involves removing and examining a sample of nerve tissue, usually a sensory nerve from the lower leg called the sural nerve biopsy. And although a nerve biopsy can provide the most detailed information about the exact types of nerve cells and cell parts affected, it can further damage the nerve also and leave chronic neuropathic pain and sensory loss. So we will only do this if absolutely needed. Neurodiagnostic skin biopsy is yet another test which allows specialists to examine nerve fiber endings following the removal of only a tiny piece of skin, a little tiny piece of skin, usually about 3 millimeters or so in diameter, under local anesthesia. Skin biopsies have become the gold standard for diagnosing small fiber neuropathies that don't affect standard nerve conduction studies and electromyography. Next, for suspected autonomic involvement, testing involves the QSART test, which measures the ability to sweat in several sites in the arm and leg. Abnormalities in the QSART are associated with small fiber polyneuropathies. Also, we can do radiology imaging, such as an MRI of the spine, which can reveal nerve root compression or a pinched nerve. It can also reveal tumors or other internal problems. MRI of the nerve or a neurography can show whether there's any nerve compression. A CT scan of the back can show herniated discs or spinal stenosis, or a narrowing of the spinal canal, bone and vascular irregularities that may affect nerves. All three of these tests would be considered if there's a question of whether there's more of a mechanical reason for the peripheral neuropathy. Muscle and nerve ultrasound is a non-invasive experimental technique also for imaging nerves and muscles. For injury such as like a severed nerve or a compressed nerve, ultrasound imaging of the muscles can detect abnormalities that may be related to a muscle or nerve disorder. As certain inherited muscle disorders have characteristic patterns on muscle ultrasound. I did not know this before making this video, so this research actually helped to enlighten me as well. I mean, as I said, I always learn myself when doing these videos. So what treatments are currently available for PN? First, any treatment will depend entirely on the type of nerve damage and the symptoms and the location. Your doctor or nurse practitioner will explain how nerve damage is causing specific symptoms and how to minimize and manage them. So with proper education, some people actually may be able to reduce their medication dose or manage their neuropathy without medications entirely. Definitive treatment, though, can permit functional recovery over time as long as the nerve cell itself has not died. So this is really good news. The first step is to address the neuropathy's causes. So correcting the underlying cause can result in the neuropathy resolving on its own as the nerves recover or regenerate. Inflammatory and autoimmune conditions leading to neuropathy can be controlled using immunosuppressive drugs such as prednisone, cyclosporine, and azathioprine. Another option is plasmapheresis, which is a procedure where blood is removed, cleansed of immune system cells and antibodies, and then returned to the body. And this can help reduce inflammation or suppress immune system activity. Agents such as rituximab that target specific inflammatory cells is also often prescribed, as is large doses of immunoglobulins or IVIG, which are antibodies that alter the immune system and can suppress abnormal immune system activity and provide a huge benefit due to its anti-inflammatory properties. Specific symptoms can usually be improved, so for motor symptoms, mechanical aids such as hand or foot braces can help reduce physical disability and pain. Orthopedic shoes can improve gait disturbances and help prevent foot injuries. And splints for carpal tunnel can help position the wrist to reduce the pressure of the compressed nerve and allow it to heal. Some people with severe weakness benefit from tendon transfers or bone fusions to hold their limbs in better position or to release a nerve compression. Autonomic symptoms require detailed management depending on what they are. So, for example, people with orthostatic hypotension, which is a significant drop in blood pressure when standing up too quickly, can learn to prevent drops by standing up slowly and taking medications to improve blood pressure swings. Many people use complementary methods and techniques such as acupuncture, massage, or herbal medications, and cognitive behavioral or other psychotherapy approaches to cope with neuropathic pain. These people will also sometimes have hydration infusions to aid in this symptom management. Sensory symptoms such as neuropathic pain or itching caused by injury to a nerve or nerves are more difficult to control without medication, and some people will use behavioral strategies to cope with chronic pain, as well as the depression and anxiety that many feel following a nerve injury. It is a debilitating thing to go through. Chronic pain is exhausting, and I talk to people every day with it. Many are IVIG recipients, and that struggle is there's no other better word to describe it. It is an exhausting struggle. Medications recommended for other medical conditions are also used for chronic neuropathic pain or neuropathy. Among the most effective are a class of drugs first marketed to treat depression, I believe, and that was nortriptyline and the newer serotonin norepinephrine reuptake inhibitors such as duloxetine hydrochloride modulate pain by increasing the brain's ability to inhibit incoming pain signals. Another class of medications that quiets nerve cell electrical signaling is also used for epilepsy, and these include gabapentin, pregabalin, and less often topiramate and lamotrigine. Carbamazepine and oxcarbazepine are particularly effective for trigeminal neuralgia, which is a focal neuropathy of the face. So local anesthetics and related drugs that block nerve conduction may also help when other medications are ineffective or poorly tolerated. Lidocaine patches or creams are examples of this and can be applied to the skin for help with small painful areas such as localized chronic pain from mononeuropathies such as shingles. And another topical cream is capsaicin, which is actually a substance that is found in hot peppers and can desensitize peripheral nerve pain and the peripheral nerve endings. Doctor-applied patches that contain higher concentrations of capsaicin offer longer-term relief from neuropathic pain and itching, but they can worsen small fiber damage. So be very careful if you're using that or you're prescribed it by your doctor, or if you are prescribing it for one of your patients, if there's any healthcare practitioners out there working, just keep that in mind that this can actually lead to nerve damage. Next is narcotics or opioids, and they can also be used for pain when it doesn't respond to other pain control medications and if disease-improving treatments aren't fully effective. And one of the newest approved drugs for treating diabetic neuropathy is tapentadol, which has both opioid activity and the norepinephrine reuptake inhibition activity of an antidepressant. So that's actually pretty cool. Surgery is the recommended treatment for some types of neuropathies, protruding discs or pinched nerves, for example, in the back or neck, that compressed nerve roots are commonly treated surgically to free the affected nerve root and allow it to heal. Transcutaneous electrical nerve stimulation, or TENS, is a non-invasive intervention used for pain relief in a range of conditions. TENS involves attaching electrodes to the skin at the site of pain or near associated nerves and then administering a gentle electrical current. And although data from controlled clinical trials are not available to broadly establish its efficacy for peripheral neuropathies, unfortunately, in some studies, TENS has been shown to improve neuropathic symptoms associated with diabetes. So the good news here is that there are several treatments for neuropathy sufferers, but prevention is typically the best way to go if you can. Few of the most effective treatments for PN are IVIG and sub-Q IG and plasmapheresis, but deciding on which one is best suited requires a basic understanding of how they work and a lot of research and careful consideration. But I've done all of that work for you just to give you a head start right here. So that's it for this month's review of peripheral neuropathy. I hope you guys got a lot out of it. There is a vast amount of information out there, and trying to condense it for this video was challenging. So I highly recommend to check out some of our other videos because there's absolutely very specified information in there about IVIG, plasmapheresis, the differences between IVIG and sub-Q IG. And if anybody is watching this who's suffering from peripheral neuropathy, these are things you absolutely need to know about and understand in order to make informed decisions about your care and your treatment. So check them out. As I said, I think you'll find them really super useful. Unfortunately, I couldn't put them all in this video. And then if you want to laugh, you can check out some of my reaction videos, which I've done like 3 so far at this point, and some of the memes out there, I said it in the last video, some of the memes are just so damn funny and so accurate and truthful. So